Bismillahir Rahmanir Rahim. Today we are going to discuss a type of pituitary adenoma known as the prolactinoma. Prolactinoma is a benign tumor that arises in the electrotrope cells of the anterior pituitary gland, and these are functional benign tumors that cause excess secretion of the prolactin with the downward effects of the prolactin. We classify the adenomas that arise in the pituitary gland on the basis of the hormone production. For example, the somatotrope cells will lead to somatotrope adenoma, which will result in excess secretion of the growth hormones. The gonadotrope cell adenoma will result in the excess secretion of the gonadotropins, the FSH and LH. The thyrotrope adenoma will result in the production of excess TSH, which that will cause thyroid gland to cause excess secretion of the thyroid hormones like T3 and T4. Adenomas are also classified on the basis of either they are non-functional, which will cause only the mass effects, or if they are functional, then there will be excess secretion of the hormones and with their effects. Adenomas are also classified as familial, that run in families and that are associated with inherited genetic mutations, and the non-familial adenomas which arise sporadically. Adenomas are also classified as large adenoma or macroadenoma, which when the adenoma is more than 1 centimeter in diameter, and microadenoma are small adenomas in which the tumor is less than 1 centimeter in diameter. The types of pituitary adenoma: the prolactinoma, which is the prolactin secreting tumor that arises in the electrotrope cells, is the most common pituitary adenoma. The somatotrope adenoma associated with excess secretion of the growth hormone is the second most common type of pituitary adenoma. The third most common benign adenoma of the pituitary gland is the adrenocorticotropic hormone producing adenoma that will cause excess secretion of cortisol from the adrenal glands, and this is known as the Cushing disease. The gonadotropin producing adenoma will have their effects on the sex organs in the females and males. The TSH producing adenoma are rare and they will have their effects on the thyroid gland by causing excess production of the thyroxine and triiodothyronine. And there are non-functional adenomas. They do not secrete excess hormone secretion, but they exert their effects mainly because of their mass are a macroadenoma that will compress the structures, surrounding structures of the pituitary gland and the sella turcica, the bony sac in which the pituitary gland is situated. Prolactinoma is the most common type of pituitary adenoma, and it is a tumor that arises in the electrotrope cells and that secrete excess prolactin secretion. The pathological effects of a prolactinoma may be due to the presence of a macroadenoma that will exert mass effects, and if it is a functional tumor, it will cause excess secretion of prolactin and that have different effects in males and females. In female, the excess prolactin secretion will cause milky discharge from the nipple, and that condition is known as galactorrhea. By inhibiting the gonadotrope hormone secretion, excess prolactin secretion will lead to loss of menses in a female. The condition is known as the amenorrhea. By inhibiting the gonadotropins, the excess prolactin also cause decreased production of the estrogen, and we know that the estrogen, it inhibits the osteoclasts, which are the bone which are the cells that cause bone resorption and breakdown of bones, and in conditions where the estrogen is inhibited by excess prolactin, the uh, osteoclasts are free to cause bone breakdown, and the condition is known osteoporosis, in which the bones, particularly in an old age female, becomes very susceptible to fractures. Now, in the males, excess prolactin secretion will cause enlargement of the breast. The condition is known as the gynecomastia. Also, the inhibition of testosterone from the male testicular tissue, the excess prolactin may cause sexual problems, for example, erectile dysfunctions. Now, before going to discuss prolactinoma, let us have a look over the normal production of the prolactin. Prolactin is produced by the lectotrop cells of the anterior pituitary gland, and prolactin, along with some other hormones like uh, progesterone in the female, and the during pregnancy the human placental lactogen, and along with the oxytocin that is produced by the hypothalamus and stored in the posterior pituitary gland. All these hormones, they are involved in the synthesis, production and secretion of breast milk in a breastfeeding female. The prolactin inhibits the secretion of the gonadotropins, mainly the luteinizing hormone and the follicular stimulating hormones, and we know that the gonadotropins have effects on the ovaries by increasing the female sex hormone known as the estrogen, and in the male they increase the secretion of testosterone, which is the male hormone. Now, normally in a female, if she is not pregnant or if she is not breastfeeding, the secretion of prolactin is persistently inhibited by an inhibitory hormone that is produced by the hypothalamus, and that is known as the dopamine. The dopamine is constantly released except during pregnancy and during lactation, and it will inhibit the secretion of prolactin from the lectotrop cells of the anterior pituitary gland. Another stimulus for the secretion of prolactin is the thyrotropin releasing hormones from the hypothalamus. And therefore, in investigating the patients of prolactinoma, we also measure the level of the TSH and TRH. The estrogen also has a positive feedback effect on the secretion of prolactin, and it causes increased secretion of prolactin. Additionally, the sucking reflex of of a baby on her mother breast nipple is a stimulus for the secretion of prolactin. Prolactin itself, when its level runs high in the blood, it causes a negative feedback inhibition of its secretion by the anterior pituitary gland and hypothalamus. And this effect of the prolactin inhibition is brought about by the secretion of dopamine, which is the prolactin inhibitor, which is an inhibitor of the prolactin secretion by the hypothalamus. Now, what happens that the prolactin during pregnancy and during breastfeeding, it will inhibit the secretion of gonadotropin releasing hormone from the hypothalamus. And we know that the GnRH or gonadotropin releasing hormone produced by the hypothalamus causes increased secretion of the gonadotropins FSH and LH from the gonadotrop cells of the anterior pituitary gland. So during pregnancy and breastfeeding, the prolactin have a negative effect through hypothalamus by inhibiting the secretion of the follicular stimulating hormone and luteinizing hormone, and this will lead to uh, inhibition of the estrogen secretion by the female ovaries, and this will lead to amenorrhea. So during pregnancy, the prolactin inhibits FSH and LH secretions. But during pregnancy and during the lactation or breastfeeding period, the excess prolactin that is secreted uh, along with the human placental lactogen that is secreted by the female placenta, and also the progesterone that is also secreted by the placenta, and the oxytocin which is produced by the hypothalamus and stored in the posterior pituitary gland. So collectively these hormones, the prolactin, human placental lactogen, progesterone, and oxytocin, they will cause growth of the glandular tissue in the female breast, and during lactation, they will cause increased production of milk. Now, why a prolactinoma occurs? This is because of the mutations that occur in the lectotrop cells of the anterior pituitary gland, and the lectotrophs, due to mutations, undergo uncontrolled cellular proliferation and grow into a mass known as prolactinoma. Now, the effects of a macroprolactinoma or prolactinoma with a large size include compression of the optic chiasma and the optic nerves. And this will lead to bitemporal hemianopia, in which we can only see in the central region, but we don't see anything on the lateral margins of the visual field. And this is also known as the tunnel vision, because it is just like to see through a tunnel. So the disturbances of the vision occur due to compression of the optic nerve by a large size prolactinoma. This large size prolactinoma will also compress the meninges, which are the protective coverings of the brain, and they are very sensitive to stretch, and when they are stretched by a macro or enlarged prolactinoma, they will cause severe pain. Prolactinoma, if it is less than 1 centimeter or 10 millimeter in size, it is known as the microprolactinoma. And mostly the microprolactinomas, they are the patients are asymptomatic. But in prolactinoma or macroprolactinoma, when their size is more than 1 centimeter or more than 10 millimeter in size, they will produce the effects due to the mass effects due to the presence of an enlarged adenoma, and these effects include the visual disorders and stretching on the uh, meninges, which will cause severe pain. Now, coming to the functional disorders associated with the prolactinoma, we know that excess prolactin secretion have a negative feedback effect through hypothalamus on the gonadotropin releasing hormone. And lack of gonadotropin releasing hormone that is caused by the excess prolactin secretion will cause decreased secretion of the gonadotropins, the FSH and LH. Now, decreased secretion of FSH and LH in the ovary will result in decreased secretion of the estrogen. And we know that normally the estrogen, it inhibits the activation and differentiation of the osteoclasts. And the osteoclasts are the cells that cause bone resorption or breakdown of bones and release of calcium into the serum. So, in conditions of prolactinoma, when there is no estrogen secretion, the osteoclasts are free to cause bone resorption, and this condition is known as the osteoporosis. And here, particularly in an old female, she is very susceptible to fractures due to the brittle bones. The excess secretion of prolactin that normally inhibits ovulation and cause amenorrhea, but that will be the condition during pregnancy and during lactation. But in a patient with prolactinoma, if the patient is not pregnant and she is not lactating, but she develops amenorrhea, and this is mainly due to the negative feedback inhibition of the gonadotropins. Now, in a male, normally the prolactin, when it inhibits the gonadotropins that have got effects on the testicular tissue to cause spermatogenesis, what will happen that in conditions of excess prolactin secretion, there will be inhibition of spermatogenesis, decreased production of testosterone, and the male will suffer from sexual disorders like erectile dysfunction, and also the male suffer from gynecomastia, which is enlargement of the male breasts. A microadenoma, mostly it may be asymptomatic, but a large prolactinoma or macroprolactinoma or macroadenoma, it will cause vision problems due to compression of the optic chiasm and optic nerves. It will cause headaches due to compression of the and stretching of the meninges. It will cause galacturia, milky nipple discharge, even if the patient is not pregnant and even if the female patient is not lactating. The patient will develop amenorrhea even in the absence of pregnancy. And the lack of estrogen will cause dryness of the vagina and problems during sexual intercourse. And inhibition of the estrogen will allow the osteoclasts free to cause bone breakdown and osteoporosis, and particularly in the old age female, she will be very susceptible to bone fractures due to minor injuries. In the male, it will cause gynecomastia and erectile dysfunctions, while in both the sexes, in both the males and females, they will experience loss of libido, and this will lead to infertility issues. Now, to make a diagnosis of the prolactinoma, we look for the signs, symptoms, and we measure the prolactin level in the blood, and in conditions of prolactinoma, there will be hyperprolactinemia, high level of prolactin in the blood. Since we know that TSH also promotes the secretion of prolactin, therefore, in patients of prolactinoma, we also measure the TSH level because it stimulates prolactin secretion. We do imaging techniques like MRI to make and to assess the size of prolactinoma. If it is a microprolactinoma or microadenoma, or if it is a macroadenoma, that will exert their effects due to the presence of a mass of tissue in the sella turcica. We have got two options for the treatment of the prolactinoma. Usually, initially, we give dopamine agonists that work like dopamine and binds to the receptors of dopamine receptors in the anterior pituitary gland. The two most common uh, drugs are the bromocriptine and cabergoline, and they will inhibit the release of prolactin from the anterior pituitary and will cause decrease or regression in the size of the prolactinoma. If the medical treatment fails, then we go to the surgical option, and in surgical treatment, in the neurosurgery, there is surgical excision of the prolactinoma. And this will be particularly considered when the prolactinoma has got a large size, or if there is if the medical treatment are giving dopamine agonist fails. But sometimes, even after surgical removal of a prolactinoma, the prolactin secretion remains high. And in this situation, we will consider radiation therapy. Some important points related to the prolactinoma is that prolactinoma may undergo dystrophic calcification. Dystrophic calcification is the abnormal deposition of calcium along with other salts like other minerals in areas of tissue necrosis. And in this situation, the abnormal deposition of calcium occur in the anterior pituitary gland, and they may be in the form of multiple or isolated samoma bodies, which are whorled masses of phospholipids and calcium. And sometimes there may be so much extensive calcification that the entire pituitary gland is converted into a pituitary stone. The second important point, that any mass in the sella turcica or supracellular compartment may disturb the normal inhibitory influence of the hypothalamus on prolactin secretion. So this may not be a prolactinoma, but this may be an adenoma or in the other trop cell population, but it will inhibit, it will disturb the inhibitory influence of the dopamine on the anterior pituitary gland, with the result that the prolactin secretion is accelerated or activated, resulting in hyperprolactinemia. So for this reason, if there is mild elevation in the serum prolactin of a patient with another pituitary adenoma, not prolactinoma. For example, it may be somatotropsil adenoma, or it may be gonadotropsil adenoma, not prolactinoma, but still there is a mild elevation in the level of the serum prolactin, and this is due to the loss of inhibitory effects, allowing the hypothalamus to increase the secretion of the to decrease the secretion of the dopamine, which will cause excess secretion of the prolactin. So this mild elevation of prolactin may also occur in other types of adenoma, and it may especially be considered. We know that prolactinomas are treated surgically or medically by drugs that act as agonists of dopamine and inhibits prolactin secretion. Thank you very much.